Hi, everybody. So, we are going to talk about clinical assessment, diagnosing, and treatment. Just a brief overview to help you understand. So, why do we assess clinically? And what does that look like? It helps us determine the best treatment for an individual. And I want to make it really clear that during assessment, a lot of times, yes, the initial session is an intake, but it's an ongoing process. It's not a one-time thing. And so, what's bringing somebody into therapy? We need to assess these things. We need to look at their background. We need to look at their history. We need to look at um, their relational history. So it's an ongoing process. That's why I wanted to highlight that, in which a professional collects information and you have to draw some conclusion, not only through the history that they tell you, but tests that you have them. For instance, I have clients fill out in their intake form, it's called a GAD-7 and PHQ-9. A lot of times at the doctor's office, they will have you fill these out, and it's a quick sort of self-reporting assessment for depression and anxiety. Okay, now that's going to help you with your assessment when somebody fills that out. If they score relatively high, that's going to give you some clues to explore more, look into that more. Um, it's also through observation. It can be through neurological tests. It can be through interviews. But again, I want you to think of it as like an ongoing process because the thing is as a clinician, I might assess somebody in one session and it's looking like depression, but then come to find out maybe they had a recent death and a close death in their life. Maybe it's looking more like bereavement, right? Which depression is a part of bereaving for somebody. And so that's why it's a really important kind of process, okay? Um, and let's see. So clinical interview, that's probably kind of the gold standard. It's the intake session, it's asking questions. It could be structured. Sometimes you may have to do like a life inventory where you have the client fill out, I mean, they can be up to 20, 30 pages long. I typically don't do that. I feel like since it's an ongoing process, I tried to ask, the very important questions. What's bringing you in today? Why now? Because I really want to focus on the here and now. And then I definitely want to obtain the history of like if there's suicidal ideation, is there any attempts? Those sorts of things help me pinpoint areas of their life that may need to ask more questions in. Sleep is also a big factor. If somebody's having a lot of anxiety and then they're not sleeping, are they drinking too much caffeine, which only increases their anxiety? These are all just kind of different hypotheses and conceptualizations. Okay. Um, so observation, the limitation can be the person may automatically feel really nervous coming to therapy, right? Or seeing a professional. And so they may automatically be acting, they could be reducing or minimizing their symptoms, right? And so observation alone is not enough information. However, if you're observing something, you can ask questions. Hey, I'm noticing every time I'm asking about your family history, it seems like I'm seeing you kind of fidget your hands a little bit more. Can you tell me more about that? So I'm not like trying to call out them fidgeting their hands, right? And naming it like that's your anxiety. It's more of like curiosity and exploring with them. Um, Assessment methods, if we're talking about neurological tests, we could be PET scans, MRI, CT scans. Psychotherapists are not going to be doing that type of testing, but that is still an assessment tool, right? To see if there's any inflammation, to look at areas of the brain that gives doctors information about that. The same is true even for psychology, right? Not that we're going to have maybe the same exact tests, but they help us to gather information, to learn more about what could be going on. Psychological tests and inventories. You may have heard of the MMPI, the Minnesota Multiphasic Personality Assessment. And that is a pretty thorough personality test. And so it's pretty lengthy, right? Some of these tests are lengthy, but there is a lot of reliability and validity in these tests. Okay. There's also physical examination. This is not psychotherapist, right? But this is more like just in general, different assessments you've probably taken before. If you play sports in school, you have to get a physical exam to make sure you can perform in that sport, right? Okay. So a physical exam, you may refer somebody to a physician, to their primary care doctor to ensure there's not any biological factors going on. We do this a lot with erectile dysfunction. A lot of times, a high percentage of erectile dysfunction may be a psychological, it could be performance anxiety. But we don't want to assume that. We want to rule that out, that there's not anything physiological going on. There is a correlation with cardiovascular disease and erectile dysfunction. So this can also be preventative. We always want to rule out if there's something physiologically going on. Okay, there's intelligence tests, there's behavioral tests. And so, clinical diagnosis, okay? So, a diagnosis is really this process of using this data, okay, that we talked about through assessments, through maybe self-reporting. And that way, that helps us determine if there's a pattern of symptom that the person really seems to be consistently presenting with, okay? Because people will use the term like, oh, I was so depressed yesterday. Okay, and while you can have symptoms, right, and some criteria of maybe depression, to actually get a diagnosis of like depression, there needs to be a consecutive symptomology for 2 weeks straight, right? And so it's important that as clinicians, we're gathering this information. So that's what we mean by they're presenting with this consistent. It's not one day on, one day off, right? And we really gather this information and then we refer to the Diagnostic Statistic Manual. Now it's the DSM-5 to help us in that process of diagnosing. It also helps us with prognosis, coming up with a treatment plan, and possible outcomes for this treatment. So really, it depends on the different diagnoses, but it really helps gather information and come up with a treatment plan. But here's the thing, treatment plans can and do change, right? Again, if somebody maybe we have a hypothesis that they're coming in from depression. Sometimes situations happen where new life events happen while the person is in therapy. And so the treatment plan may shift. Somebody may be going through a divorce, and so they're going through an adjustment period. And so we really need to assess and reassess the treatment plan. So the DSM has been around for a really long time. It has gone through major changes to varying degrees, things taken out, things refined. As we learn more and more about human behavior, the human brain, it's good that we are revising these things and really kind of understanding them. And so the fifth edition was released in 2013. Little fun fact, I was trained and learned all in school. I graduated in 2011. And so I had really learned through the DSM-4, right? And so there was major changes, but with anything, we adapt and we pivot, right? Okay. So the elements of a diagnosis, okay, a lot of us maybe relate to different um, to different diagnoses. In this class, that happens a lot. It's very common. But really, the person must meet diagnostic criteria or the guidelines. And each diagnosis will say must present 5 out of the 9 symptoms. So it really depends on the diagnosis, but they must meet. So all of us can relate to some of the criteria, meet some of it, but a full diagnostic criteria means you have to kind of fall within those guidelines. You can assign a subtype. So maybe the way that a certain disorder presents for an individual, there are lots of different subtypes. Just to give you an example, though, a person can have mild depression that's recurrent, right? And then you can have a subtype with anxiety, right? That can be a subtype. Or maybe they have a subtype with maybe a little bit of paranoid thoughts. Okay. And so that's just kind of really honing in on this specific person and what you're seeing in those subtypes. There can be level of severity. So a person can actually be in remission of depression, but has a long-standing history. So you still maybe want to have that noted. Um, you can have moderate anxiety, right? You can have mild depression. And so we kind of have this level of severity. And again, it's an ongoing process, so that can change. There are disorder categories. And the DSM is changing where we do change certain categories. I believe that like OCD used to be an anxiety. Um, and I'm drawing a little bit of a blank here. I don't have my DSM in front of me. But we have kind of separated some of these diagnoses. Before we had something like Asperger's on the autism spectrum, right? That's been omitted now. And so these categories can change. So we have neurodevelopmental disorders, we have schizophrenia spectrum, we have bipolar and other related. We have depressive. There is anxiety. Okay, see right here. And then we have obsessive compulsive, which we have separated from anxiety, the old DSM. We can have trauma and stress related categories. So PTSD, acute stress disorder. And then there can be disassociative, depersonalization, derealization. Mhm. We also have sexual dysfunctions. Those are also in the DSM. Gender dysphoria, disruptive impulsive control. And then we also have substance related diagnoses as well. Cannabis, abuse, cannabis dependence, alcohol abuse, alcohol dependence. Okay, I like this little blurb of 5 signs to seek therapy. And of course, this is not the end all be all. There's lots of really good reasons as a clinician. I think everybody is deserving and can benefit from therapy if they're willing to do the work, right? So, some 5 signs: if you feel sad, angry, or not like yourself, something has shifted. Maybe people are noticing, you're noticing. If you are abusing drugs, alcohol, food, or sex, it's a good time to really kind of, hey, maybe I can't do this on my own. If you've lost a loved one or something important to you, there's been major loss, major life transitions. If you've suffered a traumatic event, right? And that doesn't have to mean war, that doesn't have to mean, um, an accident, right? This can be any life-altering event that we used to think of trauma as like something, categorized only in, war veterans or abuse victims. But a traumatic event is anything that really disrupts our regular life, right? If you stop doing the things that you used to enjoy the most, that's a really good indication. It's called anhedonia, where you have a loss of interest in things you once enjoyed. So I like this. I mean, there's obviously more. Don't feel like it's only these five signs, but it's a good thing to reflect on and say, hey, could I benefit from this? So, what about friends and family? So, a lot of times people will say, well, I have friends and family. I don't need a therapist. And I want to make it really clear that family and friends are amazing and of good support. And they're a vital aspect to our support system and our macro and micro system, right? But they often don't have the training and background that a psychologist, that a psychotherapist, or a similar professional has really gone into the field and trained in, right? I hear it a lot from people, well, I'm basically a therapist, right? And while maybe you are a good listener and you are a helper in that realm, and that's a beautiful thing. That's not all that entails in being a therapist is being a good listener, right? It's being able to conceptualize what the person's telling you, look at patterns, um, have training and background in something to help with that modality, like uh, EMDR, right? To help somebody with post-traumatic stress disorder maybe really work through their trauma. And so, a lot of times, even though family and friends are beautiful and amazing, a lot of times their advice is really coming from their own experience. And not to say that there isn't wisdom in that. However, it is based on their own experience and not necessarily from empirical evidence or other research. So, what is psychotherapy? So, it is a process which psychologists apply scientifically validated procedures that help people develop healthier, more effective habits. So this is kind of just solidifying what I was sharing about, therapists versus friends and family giving advice, we really try to come from the background of research and empirical evidence and evidence-based practices that have shown reliability and consistency and have helped people, and that there's been extensive research in that. And so this isn't just a matter of this is our opinion, right? A therapist's job is not to just give advice. We are really trying to help the clients navigate in new ways with evidence-based practices. The other thing that's really important to emphasize is therapy is a collaborative effort between the client and the professional. It's not a power differential. It's not about the therapist knows everything. Um, this is really a collaboration of I'm going to enter your world and I'm going to join you wherever you're at. And I'm going to have unconditional regard, like Carl Rogers really believed in just having this unconditional regard towards the client of I'm not here to judge, I'm here to create space for you. For some people, people have never done that for them. And so that is going to be important is I'm going to help be there for you while you're navigating this kind of new territory, right? Let's look at therapy as like we're entering new territory that you've never gone before. And so you don't have to do it alone, but just because I have, a psych background, just because I'm licensed in it does not mean I know and have all of the answers. Um, and research has shown that about three-fourths of those who undergo psychotherapy experience some benefit, right? I always tell clients, I feel like you get out of therapy what you're willing to put into therapy because people do have a misconception. And I tell people, I do not have a magic wand. I can't fix everything for you. But the hope is that by us talking about it, by finding maybe new ways to reframe it, Maybe we look at different modalities that I use. Like I said, EMDR for PTSD symptoms. The hope is that you can, feel supported, you can feel empowered, but there's never, 100% cure in psychotherapy. Also, a good fit therapist. So the research shows over and over again that the therapeutic relationship is one of the most important aspects of therapy. So unfortunately, people will go to therapy and have a really terrible experience because the therapist was maybe not a good fit for them. And then they never try another therapist or therapy again because they think all therapy is like that. Okay. So I just want you to look at that number. About three-fourths of those who undergo psychotherapy experience some benefit. If people are more closed off and maybe have more rigid systems internally, I'm talking about, they don't maybe like to ask for help. And so somebody may give them advice and say, hey, you should really think of going to therapy. And so they do that and they check off the box. And really, they're not open to hearing from another point of view. Maybe they're not ready yet. And so those people might report, I didn't get any benefit from it, right? And they just simply may have not been ready to maybe look at that stuff. And that's okay. It doesn't mean therapy doesn't work. It means maybe it wasn't a good fit. Maybe they weren't ready to enter into it. And that's why I say at the very beginning to really kind of talk about the expectations with clients of therapy is what do you hope to get out of this? What are your expectations? Because sometimes people will put unrealistic expectations on the therapist, on therapy. Well, I want you to make it all better. I want you to fix it. And so, if you can really hone in on these things in the very beginning during the assessment process, you can really talk about maybe their expectations versus the reality, right? And then I always say, hey, a lot of times you get out what you put in, and it's maybe 1% what we're doing in these sessions once a week for 50 minutes a week, but it's really 99% of what are you doing outside of therapy? Are you journaling? Are you finding tools, to really think about these things? Some people will spend the 50 minutes, they're all in therapy, and they don't ever think about our sessions after we talked about something. That may be a defense mechanism. That may be something they really want to start to look at because think about that. Like it's 1% therapy, 99% what you're doing outside of there. Therapy may be a safe place where they want to contain these things. But man, can you imagine if you were willing to really look at this throughout the week? And then come back to me and report back what you learned from our session. Sometimes I'll be like, how are you doing after our last session? We had a really big, discussion on your feelings or maybe something that came up. I didn't even think about it. And that's really telling, right? And so I just want you to think about three-fourths of those who undergo psychotherapy experience some benefit. You get out of therapy what you're willing to put in. And some people are not ready, and that's okay. The duration of treatment really depends on the type of problem, the patient's history and goals, and how quickly the patient makes progress. Things like therapy, I'm sorry, insurance. Insurance sometimes won't have prolonged therapy sessions that they cover. They may only cover 6 to 10 sessions, right? And so, like, these are different factors. A lot of times people think more short-term based therapy um, is more beneficial. I would say it really depends on the person. A lot of times I've worked with some clients for years upon years, and they have long, extensive trauma histories. And so building trust and rapport takes time than it does. Um, for others. And so, can you imagine if somebody finally opens up, and they start to build trust with their therapist, and then it's like, well, 6 sessions are up. And so, I'm not a big proponent of just short-term therapy works. I think it can, I think it depends. I think it's the person, the history. And so, but again, I think everybody can benefit. You get a tune-up on your vehicle. You need to go get your oil changed every quarter or so. Why wouldn't we go and get a tune-up for ourselves emotionally, right? Um, how many people would go to the doctor because of physical things that are going on because they are looking at their emotional pain too? And there is, high correlation with those. And so a lot of people may go to the primary care doctor more if they're not looking at the emotional aspects of it. It really is this holistic approach. And so if somebody can go to the doctor any number of times they want, I don't see why people can't go to therapy the number of times. But that's just my opinion. I'm obviously in the field. Maybe I'm biased when it comes to that. But I see it as one and the same. You get a tune-up on your car, you go to get a physical exam from your doctor. Why wouldn't we get a tune-up with somebody that we trust and can help us sort things out? So hopefully that helped you gain a little bit of insight in clinical assessment, diagnosing, and treatment modalities. And, we'll get into a little bit more, but hopefully it gives you a good overview.